Ashok, are you ready? Good evening, everybody. I welcome you all to the third Gurukul session presented by Pediatric Orthopedic Society of India. Today's topic is Perthes disease, all that you need to know. And we have a very good speaker, Dr. Somesh Virmani. He's a consultant at the Medanta Medicity in Gurugram from New Delhi. He did his fellowship is from Pediatric Orthopedics from CMC Vellore long back, and he's got a good experience in all pediatric orthopedic problems. So he's going to be our guru today. He's going to talk to us on Perthes for about 30 minutes, pertaining to all the important things which you as students should know and to be practicing consultants. And we're very fortunate to have two Sadgurus, Professor Gopakumar from MES Medical College in Perindalmanna. So he is one of the regular examiners for DNB exams, and I know that even last year he went to Delhi for evaluation of DNB theory papers. So he has got huge amount of experience in treating Perthes disease. And next is Dr. Hitesha from Kasturba Medical College in Manipal. And we are very fortunate to have these two people. As you know that we call the west coast of India as the Perthes belt of India, and both of them have tremendous experience in treating Perthes patients. As well as both of them are attached to medical college and have their regular examiners for DNB exams. So it's a good opportunity for all of you to interact with them and ask questions and clarify all your doubts. Before going on to the talk, I just wanted to announce about the POSI fellowships which are available. There are a lot of fellowships which is available from Pediatric Orthopedic Society of India. So those who are finishing MS Orthopedics and who are interested in pursuing Pediatric Orthopedics as your career, please log on to the POSI website, which is www.posi.in, and you can look up what are all the various fellowships are available, and then you can apply for those. So with this, without any further delay, I request Dr. Somesh to start his presentation.
Okay, thank you, Dr. Venkat. First of all, give me a minute, just. Okay, sorry for some delay. Okay, I thank, first of all, I'll thank all the POSI seniors, Dr. Dhiren, Dr. Venkat, for giving me this opportunity to talk on this such a important topic from the examination point of view. So Perthes disease, it's to explain it to you, it's a kind of, I'll just call it a avascular necrosis of the femoral head. So as you know, I understand pediatric orthopedic conditions you might not be seeing very frequently in your day-to-day OPD, but adult AVN, which is very common. So similar to that, this Perthes disease is also a form of AVN of the femoral head, but it is a childhood AVN. And like any childhood disorder, there are high chances of good healing because child has good healing potential. So similarly in this also, although AVN will occur, but usually it will heal very well. And that's why it's frequently called self-limiting condition. So basically it's a form of osteochondrosis in which AVN is there, and AVN leads to epiphyseal osteonecrosis and also chondronecrosis. And along with that, because physis, the particularly different thing in children is there, that is affected. So it will also cause some growth cessation. But after that, what will happen? Slowly and slowly, the blood vessels will come and they'll try to restore the vascularity and they'll try to restore it to as normal as possible. But that is that critical phase in between when that healing is occurring, that can be the critical phase. During that phase, the weight bearing or other muscle forces can cause some flattening of the femoral head and can cause deformity. So that's what this chart is clearly depicting. As you can see, starts with vascular insufficiency and then goes on to complete healing. To introduce Perthes disease to you, it's a very old disease. It's in fact 110 years old disease. It was recognized by Leg, Carve, and Perthes, the physician, in 1910 as a distinct entity. And I remember because I was doing my fellowship at that time in 2011, when it completed 100 years, there were special issues from all the journals, particularly from OCNA, which was edited by Dr. Professor Benjamin Joseph. And this is that issue. And similarly, a few other like JP also had a similar. But one thing to particularly note, which I highlighted also, it clearly says that it has been one of the most controversial disorder of the past century. And I fully agree, and everybody will agree that all the aspects in Perthes are really controversial. But I understand, I can very well understand the target audience of this meeting is postgraduates. So I'll try to keep those controversies away, and I'll try to present the most accepted view of the disease for you, so that you can present your cases in a better way. Okay, coming to incidence. It's a childhood disease, so can be there from 18 months up to the skeletal maturity, but mostly it occurs between 4 to 8 years of age. Mainly occurs in male, ratio is something like 4:1, and it can happen in both the hips. In fact, around 10% of cases are bilateral. Etiology, I'll not spend much time as it's a vascular phenomena. Coagulation abnormalities are bound to be involved. Exact etiology is still not known, but many factors have been implicated. Major being coagulation abnormalities, some systemic abnormalities are also involved. Some people have also found hyperactivity disorders and hereditary things to be involved in the causation of the Perthes disease. Okay, brief pathophysiology. So when this whole circle, which I showed you initially, is happening, avascular necrosis to revascularization and healing, what is exactly happening inside the hip? So that is what is important for an orthopedic surgeon like you and me to for us. So what is happening when there's an avascular necrosis? There will be some kind of inflammation, which will cause synovitis, cartilage hypertrophy, and even ligament and teres hypertrophy. There will be some effusion also. So that inflammatory changes will cause the extrusion of femoral head. That will initiate the femoral head extrusion. And once that has extruded, as you can see here, part of the femoral head is avascular, and then it has extruded. So now two things are acting. One, it is avascular, one, it is extruded. If it was not avascular, only little bit extrusion has occurred, then weight-bearing muscle forces can easily be taken care of by the hip. But once the avascular head extrudes and extrudes more than 20%, then what happens? It leads to some flattening or some deformation of the femoral head. So as I said initially, that the critical phase between revascularization, or rather avascularization till healing, is the critical phase when we as an orthopedic surgeon have to take care of the hip. If we're able to take care, result is usually good. And other conditions are also important, like other things are forgiving. But if the irreversible deformation starts, then ultimately lands in the osteoarthritis and residual incongruity, which can turn the disease into a severe cause. Now, presentation. How will the child present to us? Classically, the most typical finding which the child will come to us will be limp. Right? And classically, it is a painless limp. And when you ask the parent for how long, usually it's quite a significant period has already passed, maybe few weeks to few months. But pain will not be usually a major symptom. Mainly it will be limp. And that limp also, parents will particularly say that limp is more once the child has played for some time, usually more in the evenings. And he is better when he gets up in the morning. So such a symptom, you should definitely think about Perthes in the history. Then pain, although can be there, pain can be there sometimes in the hip region, groin, and sometimes refer to the knee also. You should take a very diligent history, and when you should do a diligent examination. Unlike other general orthopedic disorders, history is important in any pediatric orthopedic conditions, and similarly in Perthes also. Family, because you should always ask about any family history of similar disorder, because there can be some collagenopathy, some epiphyseal dysplasias, then other family members will also be affected. Always take a history of blood coagulation disorder in the child himself or in the family, because that can also cause AVN of the hip. Or if there is any history of steroid medication. I had seen a similar case when the parents, are not going into details, or parents were giving steroid, which we realized later when we could see that there was a history of similar fractures also. And then that case had bilateral Perthes. So whenever you find something abnormality, bilateral Perthes, you should try to rule out other causes also. And then if you don't find, then probably you can say that it is bilateral Perthes also. Okay, in the general physical examination, always examine height, because as I said, dysplasia and all, he will have usually short stature. Examine other joints, again to rule out the dysplasias, and other signs of hemoglobinopathies like anemia, multiple swellings, etc. On examination, what will you find? Perthes disease is very particular from this point of view, that in Perthes disease, the examination findings can vary. As I said initially in the first part, that when the child gets up in the morning, he will be better. But as he plays, his muscles become fatigued, more spasm is there, the findings will change. And similarly in stages also, there will be different findings in the early stage, and as the disease progresses, the findings will go on changing. But still, the common findings, limp will be there, which will be a combination of antalgic and Tenderberg gait. Tenderberg sign may be present. I'm not going into the details of Tenderberg sign. You have seen in the hip examination earlier, but Tenderberg sign is usually present. There will be some atrophy of the thigh also, which is almost always there. And so much so, even when the disease has entered the healing phase, this atrophy usually persists. Now, the important thing of range of motion, there's usually a loss of abduction and internal rotation, and flexion is usually less affected. Few tips for you, because I was thinking myself, how was I when I was doing my post-graduation? So as I said, that during Perthes examination, abduction and other range of motion can vary from time to time. So you have to be very gentle with the child. And when you are able to avoid the muscle spasm and gently examine the child, you can usually elicit better range of motion. And as I said, initially in the disease process, only there will be little loss of motion. For rotation, I think some people say prone, but I think prone and supine both you should do and then corroborate your findings. For abduction, it will be a good idea to put the one other limb of the child and lock the pelvis and then gently examine the pelvis so that you're able to find the proper range, the proper range of motion of the hip. Okay, as I said, the disease progresses from avascularity to revascularization and healing. So what are the stages it passes through? It passes first there will be avascularity, then head will fragment, and then healing and healed stage. Although initially given by Waldenstrom, but everybody will agree that modified Elizabeth-Town classification given by Professor Joseph for staging is much more objective and much more useful for us in the clinical decision making. So I'll go through that. Stage 1A, that is the first stage. What will happen in that the epiphysis will be sclerotic. Okay, as you can see in the X-ray here, it is sclerotic, but height is well maintained. There is no loss of height. So that is stage 1A. Now, along with the sclerosis, when there is some loss of height of the epiphysis, it will be stage 1B. But you have to be careful, there is no fragmentation yet. If fragmentation starts, it will be stage 2, okay? But 2A or 2B will be defined by how much fragmentation has occurred. If on a X-ray, we can see just 1 or 2 fissures, vertical fissures, as you can see in the X-ray here, if there are up to 2 fissures, it is stage 2. That means early fragmentation. When fragmentation is more advanced and multiple fissures are there, but that means it is stage 2B. But you have to be careful. There should be no newborn formation on the lateral or anterolateral edge of the epiphysis. If there is some newborn formation, then it has entered the reossification phase or stage 3. Stage 3 again divided into 3A and 3B. How to differentiate 3 and 3B? 3A, when newborn is there, you can see some newborn, but the newborn which you see there is very porotic. like osteoporotic bone. Okay, and it is also covering less than 1/3 of the width of epiphysis, then it is 3A. When there is a good reasonable amount of bone and a normal texture bone, then it will be called 3B. And finally, when healing is complete and there is no avascular bone, then it is stage 4. So I cannot interact, probably, I'm not sure I'll be able to do or not, but just for your, because it is important, what do you think? Which stage is this? Anybody would like to say? Okay, I'll go on. So I think this is stage something like, because
please go ahead.
Yeah, sure. So we can see multiple fissures. It is late fragmentation or stage 2B, because still I cannot see any new bone formation. So probably it is stage 2B. Another example, here height is reduced, epiphysis is sclerotic, but there I can't see any fissure or fragmentation. So probably it is stage 1B. Just to repeat again for you, as you can see here, we are starting from stage 1A, normal height, then subsequently height reduced, 1B, and subsequently going to 2B, 3A, and 3B. So once X-ray is done, although X-ray is quite sufficient for the diagnosis of Perthes disease, but other investigations are also quite important for us to decide prognosis and the plan of treatment. Few of them being MRI. MRI is very useful, particularly for early diagnosis. If the child has come to us in the early phase, and suppose in early phase, when the epiphysis is still a little sclerotic, but we are not sure what we are dealing with, MRI can be very handy at that stage. And also for the accurate visualization of the femoral head, because sometimes what will happen, we'll see that little extrusion is there, but that is only bone on the X-ray. We can't see the cartilage, how much real extrusion is there. MRI can be helpful in that. And few latest things in MRI like perfusion MRI and degenerate sequence, they are quite helpful to predict how much avascularity is there, how much is the cartilage loss, which can ultimately predict our prognosis. Then coming to the bone scan, it's a very sensitive investigation. Some people consider it much more sensitive and much more than even MRI, and it is probably for early diagnosis very sensitive. There have been few classification systems which have been described according to bone scan findings, but we have to be careful. Sometimes early bone scan do suggest much more severe condition than actually it is. Okay, the arthrography. Arthrography is a very clinically useful investigation for a surgeon. Okay, because of two reasons. One, it is a dynamic investigation. Other, it will clearly show the exact femoral head configuration and containment. And it is probably the best investigation for hinge abduction, which I'll come to in just some time. When we are doing, of course, arthrogram will be done in the operation theater under GA. At that time, we can easily assess the hip congruity in various positions. The surgeon can put the hip in various positions and see in which position the head is getting best contained. And particularly in the setting of when there is some suspected extrusion and we are planning to do some containment, which I'll explain now, arthrography can be very useful. As you can see here, there's a big bump on the anterior lateral aspect of the femoral head, which is clearly visualized by this arthrography technique. Okay, coming to the classification, I'll be a little fast here. Classification, actually, this was a point of little confusion to me when I was a postgraduate. I used to think so many classifications in Perthes disease, what is the use? So there are two types of classification in Perthes. One is for disorder severity, to see how much is the grading of the disease, which is lateral and lateral pillar, two most useful. The other two which I have written here are for the end result classification. Ideally, they are to be done at the skeletal maturity to see our end result, how good the femoral head is once the healing has occurred. Cateral classification. So it is basically according to the involvement of the femoral epiphysis. Just to make it simple for you, as I used to remember, make it simple, 1, 2, 3, 4, 4 groups, minimal involvement or something like 25% involvement, grade 1, group 1, more involvement, group 2, 75%, 3, and almost whole of epiphysis 100% is group 4. When only anterior lateral portion is affected, it is group 1. And when more is approximately half of the anterior segment is half of the epiphysis, that is more of the anterior segment is affected, it will be group 2. And when the whole of the epiphysis is sequestrated, this was a term given by Cattrall, it is called group 4. So evidently group 3 and 4 usually have poor prognosis, and 1 and 2 have better prognosis. Cattrall also gave few head at rest sign, which are like this: subluxation, gaze sign. What are gaze sign? Gaze sign is basically a V-shaped translucency, which we sometimes see on the periphery of femoral epiphysis and metaphysis. According to Cattrall, it is a poor prognostic sign. Other head at rest sign, as we can see here, the subluxation of femoral head, metaphyseal. There's a big metaphyseal cyst, if you can see here. That is a sign of, that is a head at rest sign. And lateral calcification, that also signifies poor prognosis. Okay, now coming to lateral pillar classification, which has probably much better inter-observer reliability and also much used clinically to us, is lateral pillar. It is based on radiographic changes in lateral pillar. So now the question which used to come in my mind when I was doing my post-graduation, why lateral pillar? Why are we so concerned about lateral pillar? That is because when the fragmentation is occurring, if lateral pillar is well preserved, so what will happen? Even if the lateral pillar is well preserved, what will happen? All the weight-bearing forces and will be taken care of by the lateral pillar, and the central part of the head and the other part will be well preserved. But if lateral segment is collapsed, then there's a high chance of extrusion and deformation, which I told you in the beginning. So lateral pillar is classified into 3 groups: group A, B, and C, depending upon the height of the lateral pillar. When there's a minimal density change in lateral pillar, but height is well preserved, it is group A, best prognosis. Then group B, lucency is present, but height is still more than 50% of the other side or the normal side, it is group B. But when height is less than 50%, so that means now lateral pillar is no more there to support the femoral head, that is group C. In group C, there will not be much separation between the lateral pillar and the central pillar. There was some, initially there were 3 groups only, A, B, and C, but of late group B, C also has been defined when there's a borderline height with around 50% to define between B and C, and just to classify it further. I'll just show you how the 3 groups behave. This is group A. You can see the lateral pillar is well maintained on the right hip, and end result is also good, healing, and it's a well round head. Now come to group B. You can see the height is around 50% or maybe little more than 50%. Enters the healing phase, still lateral pillar height is maintained. So it is still reasonably round head, although not as good as the group A, but still reasonably round. Now C, this is group C. In the initial X-ray, the head is almost, the lateral pillar is almost flattened, much less than the half of the original height, and then see the end result. They will usually fare bad because lateral pillar is not maintained. Okay, finally, coming to the Stulberg classification, as I said, it is something like our end result grading, how the hip has fared in the whole disease process. It becomes good to bad from group 1 to group 5. Just remember that group 1 is best when it is like a normal hip. Group 2, head is still round, but not fully round. There may be some coxa magna, but it will be still within 2 mm of the circle, so it is group 2. When the shape of femoral head has changed, it is no more spherical, it is ovoid, elliptical, then it comes to group 3. And when flattening has started, along with the change in the shape, some flattening of femoral head has occurred, but correspondingly, acetabulum is also flattened, then it is group 4. And finally, flattening is there, but acetabulum is not correspondingly flattened. So it's a kind of incongruent hip. So that is group 5. So group 1 and 2 usually are very good prognosis, very good result kind of a thing. And 3, 4, 5 become progressively better. Differential diagnosis, various hemoglobinopathies, etc., can cause avian and Perthes like presentation, which you need to differentiate, as I said earlier. Three conditions which I would like to stress in differential diagnosis is epiphyseal dysplasia, tuberculosis, chondroblastoma. How will you differentiate differential diagnosis? Again, diligent history examination is important. Epiphyseal dysplasias will be bilateral always, okay? But they can be bilateral Perthes also. How will you differentiate? In epiphyseal dysplasia, what will happen? Both the hips will be almost symmetrical, or both of them will be in the early phase, then they will be in the healing phase, and so on. But in bilateral Perthes, if you happen to see bilateral Perthes, the two hip will be in different stages. One hip is going to the early phase, the other hip might be going to the something like fragmentation or late fragmentation stage. So that can differentiate. Other difference is that other joints like spine can be involved, which will not be there in the Perthes disease. Chondroblastoma can also sometimes present, but you have to see that height of the femoral epiphysis is not reduced in chondroblastoma. And other important thing is that he will have rest pain kind of a thing also, which is not there in Perthes disease. Pain is not a prominent feature in Perthes, but it will be so in chondroblastoma. Okay, now coming to prognostic factors, as I have told you, age presentation is from 4 to 8. So depending upon, according to the presentation of the classification, lateral pillar and other factors, few prognostic criteria have been defined in the Perthes disease. Age is probably considered to be the most important prognostic factor. Younger children, particularly less than 6 years at the age of onset, usually have a very good prognosis, and most of them will not need much of treatment also. Other important prognostic factors are shape of lateral pillar, subluxation. I think these two are very important, particularly subluxation, because once hip is subluxed, then it is very difficult to salvage the hip. And other important thing, mobility, probably one of the very important thing which is quite frequently ignored in our treatment, is also an important prognostic factor. And rest I've told you about the extent of necrosis and metaphyseal involvement and also lateral calcification. Okay, now finally coming to the treatment. Perthes disease is it's a prolonged disease, takes few years for the healing process. So similarly, treatment of Perthes disease also has to be divided in different time frames. It has 3 distinct time frames. First, early in the course of disease. Second, late in the course of disease. And third, once the healing has occurred but some sequelae are left, how to treat those. And goals, principle in all the 3 phases are different. So I don't think any Perthes talk can be complete without this slide. So as I have told you, early phase, that means stage 1 to all the way up to something like 2A, or sometimes you can say 2B also, but classically 1A to 2A will be the early phase when we can do the preventive intervention. Head has still not collapsed much, and we will try to preserve the by our intervention, try to preserve the femoral head sphericity. That will be the preventive intervention. But once the head has entered the stage 2B or 3A, it has already flattened, it has already entered the reossification phase, then we can't probably do much, and then that will be a remedial surgery. And once it has entered the healing stage or healed, then that will be the salvage or the treatment of sequelae. Early treatment. The 3 important objectives in the early Perthes treatment is improved mobility, weight lift, and then containment. I'll spend some time on the mobility because probably this is the frequently ignored thing. Preserving mobility is very, very important. Why? First, as you all know, mobility is important for any joint to function, that is there. But moreover, whatever containment or whatever surgeries we are planning to do, the prerequisite for that is good mobile hip. If hip is stiff, you cannot go ahead with any containment or any surgeries, which we'll shortly discuss. And how can we improve that mobility? By traction, physiotherapy, Petricas, which is shown here. Petricas is very commonly used by everybody, and in my practice also, Petricas is a very useful adjunct for Perthes treatment. Okay, so once the mobility is preserved, now we have to keep the hip well contained. What is containment? What does that mean? Simple, literal meaning. Containment means to keep the head contained in the acetabulum. That is containment. It should not go out. But how does containment help? I'll show you here. So if you have done cooking or if you're fond of ice cream, you know, if you when you prepare the ice cream and then you keep in some mold, okay? So the ice cream will take the shape of that mold. So now when we are passing from avascularity to revascularization and healing phase, head has become brittle and then it will become soft. So if we keep the femoral head well contained in the acetabulum during that critical phase of revascularization and healing, the end result will be a round hip. But if head extrudes out, then it will be a flat and irregular hip, which will lead to poor result. So that is the basic principle of containment. We try to keep the hip well contained, but when to contain and when not to contain. So when a child is 8 years and older and has good range of motion, whether extrusion is there or not there, we should go ahead with containment, because we know, as I told you, age is a very important prognostic criteria, and it can anytime go in the wrong direction. Other thing, don't contain. Usually young children will not need containment because they do fare well. And older children, when there's a stiff hip, or very old children also will not do well with the containment. How do we contain? It can be conservative, it can be surgical. Conservative means few braces are there, many braces are there. In fact, one of them is shown here. Many name braces are there, but particularly we use, as I said, Perthes cast and hip abduction brace, which are quite useful for maintaining particularly younger children. The most useful thing which we frequently use in our part and everywhere in the world is varus derotation osteotomy. What does varus do? It's a kind of, as you can see here, varus. How will varus help? So when you do the varus, it's kind of abducting the hip. So now you can see the red part of the femoral head is the necrotic avascular zone. So as you abduct, it will go inside the joint, and as you internally rotate the hip, it will further go inside the joint. So this osteotomy will tend to contain the femoral head well inside the hip joint and help in the healing. Okay, so what is the timing of the surgery? It should be done very early. As I said, it's in the early stages before the late portion of the fragmentation. But once it has entered the late fragmentation or reossification, then ideally it is not a useful procedure. Advantages: it will prevent the femoral head from the bad forces of weight bearing. And also few studies have proven that it helps in accelerated healing. Some children who have undergone VDRO, they will tend to shorten or they will bypass the stage of fragmentation, which will lead to early healing. But it has got some disadvantages also. One, it will cause some shortening, okay? And when the child is older, it might not remodel. There can be some trochanteric prominence and abductor limb also. Few important points about this osteotomy: we should not do too much varus. That will cause all the problems which I said. And we should add some extension and derotate also to contain the hip well and medially translate the fragment. One very important thing, as you can see here, the top screw is passing through the trochanteric apophysis. We should try to do the epiphysiodesis of trochanteric, because it will help in remodeling later and will not cause the trochanteric prominence also. Older children, varus can be combined with Salter to take care of the problem of remodeling, because it is less potential is left in the older children. Okay, now the other thing which can help in containment is innominate osteotomy. It's classically described by Salter. The osteotomy goes from AIIS to the sciatic notch, and then making the fulcrum at the pubic symphysis, it will rotate the acetabulum and help in the containment of the femoral head. It improves the anterior lateral coverage of the femoral head. But again, more so than even femoral osteotomy, you have to have a good range of motion in this before you attempt to do the Salter and, for that matter, any containment procedure. Another useful osteotomy which we can do here is shelf procedure. It is the procedure when the acetabulum is extended further. As you can see here, we use Eilich-Test graph. When there's a big head, coxa magna is there, we try to create a shelf over the femoral head. Okay, so what will that do? That will also try to contain the femoral head. Advantages is that it will preserve limb length without the trochanteric prominence, and another important advantage, it's a long-term improved coverage. As the disease will heal, it can develop coxa magna, but if you have done shelf, it will help in the later stages also. Just for the sake of completion, other osteotomy, triple pelvic osteotomy is, just I'll tell you, triple is basically in addition to the Salter cut, we just completely cut the acetabulum from the rest of the pelvis and rotate. So since there's a greater mobility, it has a much more greater potential of coverage and is useful in older children. Okay, so just to summarize the containment, because it's very important for the treatment of Perthes, there are various methods available, but you have to be careful about two things: timing of the surgery, when it should be done, and the good range of motion before you plan the containment. Coming to the treatment in the late phase, the goal in late phase, once the disease has entered the late phase, already there is some extrusion or some flattening has started, then in that phase, the late phase, it is we attempt to minimize the extent of deformation that has already occurred. Okay, we cannot now completely produce a spherical femoral head, but we try to reduce the damage. It's a kind of remedial surgery or salvage surgery. In this phase also, we can consider containment, particularly when there is no hinge abduction, okay? But we have to be very careful. Along with that, we have to tell the parents about the guarded prognosis. But ideal treatment in this stage usually is the valgus osteotomy, arthrodiastasis, or shelf acetabulostomy. What is valgus? I'll just come in a couple of slides. Another important phenomena which occurs in this late phase of the disease is a hinged abduction. What happens in this? That hip has already extruded. Now what happens, that extruded femoral head will impinge against the lateral acetabular wall. Now what will happen? That will become the hinge, and now the hinge of the hip joint motion has changed, and there will be some medial joint opening. Okay, so that will cause poor biomechanics. Along with that, stress on the anterolateral part of the femoral epiphysis. Hinge abduction is a poor prognostic factor, and it will definitely lead to early OA or the poor result. As I said earlier, arthrography is the best investigation for this. Okay, child with, usually sometimes what will happen, we are treating a child with Perthes, and then suddenly they come back with a sudden deterioration in the range of movement and pain also, which was not earlier not a significant finding in Perthes, but it will come with pain. So we should think about the hinged abduction, and they will usually have some fixed adduction deformity and decreased abduction. Classical treatment of hinged abduction is valgus osteotomy. The purpose here is to improve the joint biomechanics, okay, by restoring that arc of motion of the femoral head, and also to improve the joint congruity. How do we do? As you can see here, there's a hinged abduction. And so what have we done? We have done a valgus osteotomy. So we have moved the anterolateral part of the femoral head away from the impinging of the femoral head. So that will, although it's not an ideal treatment, but it's a kind of definitely a salvage or a remedial treatment. Other treatment options in this can be Chiari or shelf or osteoplasty, which I'll come very soon. Finally, coming to the sequelae, once it has healed in poor position or some flattening is already there, how can we now manage? Our goal here is just to improve function as much as possible. And most important goal is to relieve pain and delay onset of OA if possible. But what treatment? That will depend what kind of presentation child has. In the sequelae, child is usually present with FVI, that is femoral acetabular impingement, or GT overgrowth, acetabulum dysplasia. FVI is probably the most important thing which we usually see in Perthes. What happens that anterolateral portion of head impinges on the acetabulum. As the hip is abducted, it will go and impinge on the acetabulum. Child will usually have range of motion limitation and will also complain of pain in certain particular positions of the hip when he is doing some squatting and all. Classically, chelectomy has been used, but probably osteoplasty is recommended treatment and quite successful also. What happens in osteoplasty? I'll not go into much detail, just show you here. We just dislocate the head and try to remove that bump on the anterolateral surface of the head. As you can see here, that bump is relieved, and The two advantage this procedure provides is that that bump is relieved, impingement is taken care of. Along with that, and since we distalize the greater trochanter, there is also some relative neck lengthening, which helps in improving the biomechanics of the hip also. So Perthes disease management will not be complete unless I tell you briefly about medical management. Bisphosphonates, BMP, all have been tried. Problem with bisphosphonate is that vascularity hampers the delivery at the site. Right now, local bisphosphonates are undergoing trial and there are some encouraging results, but we still have to see how do they fare in future. Finally, take home. Perthes disease is an important topic and interesting also, particularly for your exam point of view. Diligent examination, particularly for range of motion, as I told you initially, is very important. Containment is like gold standard, and still it is important, but after particularly timing and range of motion is important. If a child presents before 5 years, most of them just need symptomatic treatment. 5 to 7, physical therapy, maintain range of motion. If there is some extrusion, containment. After 7 years, containment definitely after restoring the range of motion. Thank you.
Thank you. Thank you, Dr. Somesh. I think you have covered most of the aspects of Perthes disease. We have questions. Any questions from the students? You can check your WhatsApp, Dr. Somesh.
Yeah, sure. I'll do that. No such questions.
No questions, yeah.
No.
Okay, I think we can ask Dr. Gopakumar, what are the common questions he asked to the students?
Yeah, we can ask one of the students itself. We have a couple of students who are there. Harsh, can you, Dr. Harsh Jalan?
Yes, sir.
Yeah, you can ask a question which is commonly asked in the exam.
Yeah, one thing which the examiners are fond of asking is what is sectoral sign and what is its significance in clinical examination of Perthes?
Sir, sectoral sign means differential rotations where we see the rotation differs, the hip rotations differ with the flexion and extension position of the hip. It says about the involvement of the part of the femoral head, mostly the weight bearing area of the head, and it's a characteristic feature of avian of the head. It's a diagnostic sign for the avascular necrosis of femoral head.
Because it has produced mechanical deformation of the femoral head. Therefore,
yes, sir,
some different parts will engage the acetabulum in flexion and extension. So there may be either increase or decrease in the range of movement in flexion and extension depending upon the site of damage.
Yes,
it's called as the sectoral sign. And you should understand that this is different from differential limitation of movement, which is seen in Perthes disease. Differential limitation of movement is there is loss of abduction and internal rotation with adduction and external rotation deformity, which is usually present. Second question that is often asked is what are the causes of bilateral Perthes-like changes? Somebody can answer.
Dr. Naveen Jayaraman, are you there? Dr. Naveen, I can see your name.
Sir, could be.
Yeah, Naveen, go ahead.
So, could be because of sickle cell disease, sir, or sometimes hemoglobinopathy, sir.
Okay, good. So the common causes are bone dysplasias like multiple epiphyseal dysplasia or spondyloepiphyseal dysplasia. or it can be hematological as in the case of sickle cell disease and thalassemia, or metabolic as in the case of Gaucher's disease, or endocrine as in the case of hypothyroidism. These are all will produce features of bilateral Perthes. And I've seen cases of spondyloepiphyseal dysplasias and multiple epiphyseal dysplasias coming as cases in the DNB exam. And one should not say a classical containment treatment in those cases. And again, sickle cell disease is present in some part of the India. And if you get a case, the treatment is essentially medical treatment. And very little surgical treatment is advised in these cases, as far as I know. I'd like to get the opinion of Hitesh regarding this, as to how to manage this, what they should tell in the exam.
Yeah, actually, what you rightly said for the bilateral Perthes disease, always think and rule out the systemic problem, whatever already listed by you and Somesh, that multiple epiphyseal dysplasia, spondyloepiphyseal dysplasia. Another common differential is the hypothyroid. So if the child is short stature, you need to rule out about the hypothyroid. And the most important message for all the postgraduate, whenever we suspect about the Perthes disease, always keep in a mind a differential diagnosis without seeing about X-ray, because most of the examiner will ask, what is your clinical diagnosis? And hemoglobinopathy, sickle cell anemia, everything has to rule out in every single case to say whether this is self-limiting or not. Because Perthes will have a typical X-ray features which would be lacking in the multiple epiphyseal dysplasia and spondyloepiphyseal dysplasia. The commonest radiological difference between the Perthes and spondyloepiphyseal dysplasia or any other dysplasia, Perthes would be commonly involved on anterolateral aspect, while the anterolateral lateral pillar would be maintained in most of the skeletal dysplasia. It would be involving the central pillar. So that would be the differential part of the epiphyseal dysplasia and Perthes. From treatment point of view, yes, it would be very different, and that is the reason we need to know whether it's a Perthes disease or epiphyseal dysplasia. Dysplasia's treatment depends on the deformity and systemic issue. It would not be like a Perthes, and that is the reason if we are having sickling, why we are not treating like Perthes, because it is a not self-limiting disorder. Sickling would be a progressive disorder, while Perthes, it's a self-limiting disorder. So we need to prevent the femoral deformation, which we can't do in other places. That's why we need to differentiate. That is very important in every single exam going students. Okay,
sir. I just wanted to ask Dr. Gopakumar, when I was a student, usually when we get a Perthes case in the exam, what we are taught is to say that it is watchful observation or masterly inactivity was the treatment of choice. So what will the students, what should they say if they get a 7-year-old boy in stage 1B, typical early presenter? What should the students say in the exam? Because some old examiners are still fond of masterly inactivity, and they don't prefer prophylactic containment. So where do we stand now? What should the students say to the examiner when they get a situation like this?
Below 7 years, if there is no extrusion, I think there is a role for non-containment or treatment. But if there is any evidence of extrusion below the age of 7 years, I think it should be contained surgically. Yes, non-containment treatment can be, we usually give a petri cast or a broomstick plaster. But the problem with broomstick plaster is you need to give it in so much of abduction. Otherwise, it can go into adduction if you give it in less of abduction. And second is you cannot give the child throughout the course of healing of the disease. So nowadays, if there is any loss of abduction, I usually give a broomstick cast for in a couple of times in 2-week intervals. And after that, I will advise the child to have active range of movement exercises at home. That is all. and restrict weight bearing, because it is very difficult to tell the child non-weight bearing or use a crutches for non-weight bearing, because even if you give crutches, very often they will keep the crutches in somewhere in the house and they will be playing around. So that's a problem. We don't use any type of brace like the Toronto brace or other types of abduction braces. But abduction braces can be used in the night time, if possible. Daytime, none of the children will use it.
Will wear it. I know, sir. So I think Hitesh has got some couple of ASCIIs for the students. Hitesh?
Yeah.
Can you, while you share the screen, I'll just ask one of the students, Dr. Arvind, can you tell me what are the clinical signs, at-risk signs? So usually we know that there are at-risk signs radiologically. So the other question is clinically asked is, what are the clinical at-risk signs in Perthes disease? Arvind?
Sudden increase in pain, sir. Sudden increase in pain, sir.
Okay. Sudden increase in pain is not a clinical at-risk sign. Yeah. So this was asked to me in my exam, actually, in my DNB exam. Dr. Risha madam was my examiner. Clinical at-risk signs. Age and restriction of movements. Yeah. Those two are the clinical at-risk signs in Perthes disease. Yeah, Hitesh, you can start the ASCII.
Yeah, the answer to your question, Venkat, I heard many of the senior examiner is asking this question, but actually there is no proven original article that if all postgraduate are very confirmed, they can say it is only given by the Cattrall in textbook of Oxford textbook. Other than that Oxford textbook, nowhere reference is given for the clinical head at risk signs. If the old examiner are reading that, that is only the source of the information for clinical head at risk sign.
Okay.
Yeah. Because I heard one of the very senior 70-year plus examiner. So this is a favorite question of him, and you are correct. You would be asked for in DNB exam.
Yeah.
But there is no article since last 110 years for clinical head at risk sign. 5-year-old child with left side pain with restriction of the abduction and internal rotation. The one commonest question, what is a differential diagnosis when the person is... I can't see anybody, so you can ask Venkat.
Naveen, Dr. Naveen, you can answer this question. What is the differential diagnosis in this situation when there is restriction of abduction and internal rotation?
Sir, 5-year-old.
Whoever knows the answer can answer. You should be more interactive, guys. This session is, the whole program is for you.
Coxa Vera.
If you guys are silent, no,
the case of slip capital femoral epiphysis.
So Coxa Vera and...
Don't say slip capital femoral epiphysis at 5 years because it is extremely uncommon less than 10 years. Okay.
So Coxa Vera and Perthes.
Coxa Vera, Perthes. So always, as I said earlier, always keep in mind as a differential diagnosis. Also, what is very common in India? Every third person is infected.
TB.
Tuberculosis. So always keep in mind as a tuberculosis. We talk a lot about Perthes disease, but do not forget about tuberculosis. If person is coming on West John, you can think about Perthes first, but they are coming from northern part of India. Keep about the tuberculosis first, okay, irrespective of any other primary. The investigation of choice is X-ray. So next postgraduate, this is the frog lateral and AP X-ray. So what is this?
Harsh, you can read. What is there? Harsh Jalan?
Yes, sir. Sir, pelvis, X-ray of pelvis with both hips of a skeletally immature child, where we see the right side, the femoral head is short, is small compared to the left side.
Right side or left side?
Sorry, left side, sir. Left side is smaller as compared to the right side, and the femoral joint space looks symmetrical, sir. And on the left side, we can see there is sclerosis of the femoral epiphysis. With most probably a crescent sign is seen on the femoral head. Then in the frog lateral view, sir, we are seeing the head looks normal with normal joint space, and frog lateral view of right side is looking normal only, sir. I think left side.
Left side, the head is sclerotic, right? It is not
left
normal.
Head is sclerosis, not normal.
You can definitely see that the size is less and it is sclerotic.
Okay, sir. Yeah, left side.
Okay, so what stage is this?
So this will be stage 2B, sir.
2. Why did you say stage 2B? Anybody? You all agree with the stage 2B? No?
Daniel?
No, sir. The epiphysis is fragmented.
Epiphysis is fragmented only, it will be stage of the fragmentation. If epiphysis is not fragmented, it cannot be in the stage of fragmentation. It is in single piece.
Still in stage 1.
Then height is decreased. What sub-classification of stage? Stage 1. Height is
stage 1B.
1B.
1B, yes, sir.
Okay, the common question here also, the many of the postgraduate would be asked, what herring and cattle classification?
It's a lateral pillar less than 50%.
You cannot apply, sir.
Okay. That's Chetan is correct. It can be applied only on a stage of fragmentation. Okay. Very, very rightly. So many of the examiners' favorite question, herring and cattle and head at risk sign, but those can be only applied in stage of fragmentation. It should not be applied in early stage of disease. Okay. So the last part, how do you manage? We discussed a lot about that, 5 years.
No exclusion. We can go for non-containment.
Okay, it's non-containment and the child has been skeletally mature. It is quite okay. Second case, 6-year-old child. Stage?
Gauss. Syed Gauss. You are unmuted. You can answer. Can you answer this? Yeah, Daniel, you can answer this.
Sir, this X-ray of pelvis with both the baby view of the skeletally mature patient.
Just tell the stage.
Stage is
why are you confused, man? 1 or 2? At least you say, if you don't know the sub-classification, first you have to say that is 1 or 2.
Can you see any fragmentation? Can you see? For those of you who are not understanding, fragmentation will go from the epiphysis to the physis side. Okay, it will be run vertically. Okay, don't confuse with the... Okay, it is a stage 1. So again, with the 6 years, I'm not going in detail. You can treat conservative. Okay, next case, 6-year-old. Is it similar or something different?
the height is reduced.
Correct. 1B. So all were... Okay, how do you manage?
There is a lateral exclusion.
Okay.
Conservative.
Conservative. Okay. So what factor is modifiable by a surgeon?
Exclusion of the head.
So you can see that apart from 1B flattening, there is something else also in this X-ray, which is very important to note.
Extrusion is there.
Yeah, extrusion.
Extrusion. So whenever there is extrusion, it is a poor prognostic sign. And again, even in early stage, if it is happening, as the Gopumar sir said, under 7, only the extrusion is the criteria for containment. Okay. So how will you manage? Yes, The extrusion is 35%, is stage 1B, and this is 5 years following this. Not this case, I will say, yeah. Is it the same like others?
Fragmentation.
Yeah, Daniel, can you tell now what stage it is?
Sir, it is 2A, sir.
2. Where do you see fragmentation here?
Can you see on medial side what is here? What can you see in the lateral side?
Extrusion is there, sir.
Extrusion is there, but is it only the extrusion or something else is there? Can you see in a frog lateral and AP, what is the difference?
Lateral part of the femoral head is.
Okay.
There is a new bone formation on the medial and lateral side.
Okay. And what is happening on the AP view and what is happening in lateral view?
The hip joint is reducible and there is no hinged abduction.
Why do you see the no hinge abduction? If you see the superior joint space and medial joint space, does it look equal?
Dysplastic, like
no, it is increased on the medial side.
So what is it? If medial joint
medial joint space is increased, it's suggestive of hinged abduction. The central joint is shifted to the lateral wall of the acetabulum.
Okay, so what is the investigation Dr. Somesh has shown?
We have to do arthrogram to see how much amount of extrusion.
So this arthrogram is to, so is the, what is the interpretation? You see the adducted view, the medial pulling is not there, but in abduction view, you can see there is medial pulling of dye is there. It confirm what?
Hinged abduction.
Hinge abduction. Okay, that is a controversial. I'm not going in detail how to manage with the hinge abduction, but depends on your institute. You can answer whether it's reducible hinge, not reducible hinge, whether you can do about the valgus extension, valgus, or anything on acetabulum. Okay, quick, because we sometimes it would be asked in the exam. What is this Stulberg? What? It's a heel case. Which side is affected?
Left side is affected. Oval head
Left
with the contoured hip. It is stage 3.
Okay, it is not stage.
When it's remodeled already.
Yeah, so it is not stage. Stage should not be called.
3, grade 3.
Yeah, it is a class. Stulberg is their class. Class 1, class 2, class 3, class 4, class 5. Okay, this is class 3. Correct. What is this?
This is class 4, flattened acetabulum with the flattened femoral head on the left side.
Again, it is associated with the hinging. You can see it is hinging classically on the AP and frog lateral. Frog lateral is not getting, hip is not getting centered. Okay, and the last.
What is stage?
Class 5.
What class?
Class 5 deformed head with the contoured round acetabulum.
Correct. So it is a deformed head. It's irregular. It's called coxa irregularis. Coxa magna is large femoral head. Coxa breva is short femur neck, and irregularis means irregular femoral head. Okay. Yeah.
So you can. We have few more minutes for questions. If any one of you have any questions, this is the time to ask Professor Gopakumar and Dr. Hitesh. Somesh, do we have any questions for your phone?
Hitesh, I have a question. Like we discussed that in a non-operative treatment, we keep the child non-weight bearing. It's okay if it's a unilateral Perthes. If it's a bilateral Perthes, then how do we give non-operative treatment? Do we keep them in a bed rest?
Bilateral, there is no uniform protocol. But what we follow is there, if it is a bilateral and we are little aggressive because we will do about containment, if there is a little extrusion will be there, and we'll allow the weight bearing after 6 months.
After 6 months.
Okay.
But fortunately, the bilateral incident would be less than 8%. So it is very rare. It's not very common. And what Somesh has highlighted, the very important aspect of bilateral disease, if it is happening, is bilateral simultaneous, that is so-called synchronous simultaneous involvement. Always think about the dysplasia. Classical Perthes would be metachronous, means the both side stage would be different. So that is the very important clue for the bilateral Perthes disease. And anytime bilateral Perthes we will see, we have to investigate in detail to see it is a Perthes or not.
Right. So, Dr. Somesh, do we have any questions from delegates?
No, there's no question.
So, if there are no questions, I think we have come to the end of this. Any students, anyone wants to ask any questions? No.
Yeah, I will comment one more thing. In systemic exam, many examiner will ask a very favorite question. What will you see in a systemic examination, general examination? Many of the Perthes kit would be smaller compared to that peers. So that would be short stature.
Stature, obese.
Obese, short stature, and ADHD. There would be very common associated features in a Perthes disease. So you need to check that in a systemic examination. Second problem in what Somesh has already focused, the Perthes varies from the clinical features. So in the adolescent age group, it would be different like healed Perthes in adult, because many of the Kerala exam, they keep the old healed Perthes disease. So they'll ask, why do you think so it's a Perthes disease? So any patient from that belt between 20 to 50 degree, you need to ask childhood disorder. Always keep in mind. And another favorite question of the examiner is there, if the patient is 35-year-old, whether it is Perthes or post-septic or DDH, how it is relevant? So then in the question is there, if it is following a DDH, the head would be smaller and dysplastic. Perthes is large. You need to think about large side component. Again, even arthritis, when they go for the THR, that would be different. Again, in a post-septic or tuberculosis, you need to rule out infection. Very favorite question from the examiner point of view.
Very valid points, Hitesh.
Yeah.
Sir, for at 40 years, when we see, so when can we say that it is a post-Perthes sequelae? What are the points in favor whenever a 40 years patient comes with a hip arthritis?
Yeah, you can say it is a head is big, head is irregular. That same coxa magna, coxa breva. If there is a Stulberg 3, 4, 5, then it would be developing osteoarthritis early. So all what have shown the X-ray, it would be visible in the late stage. The head would be bigger, irregular, non-spherical, flattened. In all other pathology, like infection and dysplasia, head would not be very big.
So, sir, at that stage, what treatment should we say? Like we should say always with osteotomy or?
No, that 40 years you can't do that. Then it is
arthritis.
The arthritis.
Yeah, already arthritis.
Depends on the arthritis, depends on socio-economical status. You can do about the treatment.
Because directly if we say arthroplasty, then sometimes examiners don't agree. So we can say directly about.
So the examiner don't agree. The best answer in that situation, if you want to say, I will discuss all the points, pro and cons of all treatment. Patient want to have the sitting on cross leg in sedentary worker. Think about all and give the answer. Don't say about depends on the examiner. What patient wants, you can ask. Okay, what examiner wants.
Yeah, the other way to get out of such a situation is you can say what is practiced in your institution. That is the other way to get around it. So what is done in your institution, you can say. Yeah. Because some examiners, like for example, if you tell Dr. Rajshekharan that if you don't tell an option of arthroplasty also, he gets offended. Because if you tell arthrodesis to an arthroplasty surgeon, they'll feel bad. So that is also not good. So you can either discuss the options with the patient, or you can say what is practiced in your institution.
Yes.
So there is a question to all the faculty here from Naveen. When do we weight bear after VDRO? What is C traction? And how do we give local bisphosphonate? 3 questions. Hitesh, do you want to answer that? Weight bearing post VDRO?
Post-weight bearing VDRO, it's a controversial question. All over the world, it follows about 6 weeks to 6 months. But in our institute, we'll do till stage 3B. We don't start weight bearing. Okay.
In 3 months.
Yeah. Yeah.
Oh, stage,
3B.
you go by stage. Okay. Okay.
Stage 3B. Skin traction, not seat traction. Skin traction. We'll put the above knee skin traction. And always for the skin traction, good question. Always keep the traction on bilateral, because the Perthes patient will develop the abduction deformity if it is given a unilateral traction. That is also one of the question in Perthes disease. What are the deformity in Perthes disease when it is happening? So abduction deformity can happen due to faulty traction, unilateral traction, and adduction deformity can happen due to the hinge abduction. Otherwise, there would not be, or late stage of arthritis. How do we give local bisphosphonate? Local bisphosphonate is only done in the animal study by the Harry Kim, and there are the phase 3 trial is going on. So I can't comment on local bisphosphonate, but we'll get the answer soon.
Okay.
Local bisphosphonate.
So
postgraduate can say like same. Yeah.
So
Yes,
C-traction has also been defined for probably correction of the adduction deformity. So what they give a traction, longitudinal traction, and other they put a band around the waist and they put weight on the other side. So basically to correct the adduction deformity, it has been described for C-traction.
Okay. Right. So any other questions, comments? Nothing. Dhiren sir, can we finish the session?
Sure, please.
Yeah.
Yeah.
So I would like to thank Dr. Somesh for giving a wonderful lecture, and our Sadgurus, Dr. Hitesh and Gopakumar, for taking their time out and teaching the residents over here. And I would also like to thank Ashok Shyam and Auto TV for hosting this program. Thank you one and all. And importantly, I would like to thank all the students who have joined in today for today's session. Thank you. And next session will be on actually September 18th. We'll announce the topic and the speaker very shortly.
Okay.
Thank you.
Okay. Thank you. Thank you. Yeah.
Good night.
Yeah. Dilab, you can stop the meeting now. Okay.